All right, well, I'm sure the attendees will tick up, but let's get started. I'm excited for our conversation today. My name is Porter Leslie. I'm the CEO of Ametros, and we have two distinguished speakers with me today, Paul Sighinolfi and Kenji Saito. You know, we're going to dig into what is the some of the secrets, some of the tips, some of the guidance to achieving wellness, and especially as it relates to Ametros, achieving wellness after a settlement. And so I'm joined today by two good friends, and we're excited for the conversation. I won't go long on introductions, but first I want to hand to you, Paul Sighinolfi. You've had many decades of experience and been the executive director and chairman of the main work comp system. But also I know you have ties into the medical world, and maybe you can give our audience a little background on yourself.
Yes, thank you, Porter. I have been with Ametros now for 2 years. Prior to that, I was a trial lawyer for about 30 years, and then I was the executive director in Maine for a period of 8 years. My tie to the medical world is purely legal, in the sense that I'm married to a physician, and I have a son who is a physician. So our dinner time conversations frequently discuss medical issues and quasi-legal medical issues as well. But I'm really excited to join today with Kenji Saito to have him tell us his role as a physician. He's going to be working with Ametros as part of our medical advisory group. And I think it's pretty important for a company like ours to have a medical advisory group, because if we're going to keep on the cutting edge of what's going on with medicine, we need people who are in the trenches, who are practicing medicine, and who can tell us about what the latest advances are to make sure that the people on our platform, that is people who've settled their cases, are keeping abreast of what the medical community is doing. So that's me.
All right, thanks, Paul. And Kenji, before we hopped on, I was trying to summarize the many walks of life you've had, but you are a physician, a lawyer, a pilot. I think you also share a little bit about some culinary skills. So no further ado, Kenji, welcome to our advisory council and welcome to this webinar. We'd love to hear more about you. And then I think you have some research and resources you want to share with our audience. So we're excited to dig in.
Yes, absolutely. Thank you, Porter, and thank you, Paul. I really appreciate everybody joining me for this beautiful afternoon on the East Coast. I'm actually based out of Central Maine right now, and I'd like to welcome everyone. And the topic of achieving wellness after a settlement, which is an interesting topic that hasn't been researched a lot about, but hopefully after today, we'll ask some more questions. We can start thinking about this and the sort of the post-settlement world. How do we encourage and be able to promote wellness, and looking at how do we harmonize resiliency? When people talk about resiliency, they kind of think about, bouncing back to where you were before, especially after this pandemic that we're going through right now. How do we do that? But I like to encourage people to think beyond that. I don't want you to bounce back. I really want you to bounce forward. So that's sort of the whole concept of today, is how do we do that in the post-settlement world? And to do that, I think you need to know who I am. And for those of you who don't know me, bear with me. I'm going to go with you with some slides about who I am and sort of my bringing up and how wellness is sort of intertwined in my whole career and my lifestyle and what I do as a practice as a physician. So I started off my career, working in my parents' restaurant. I grew up in a small family business, starting off as a busboy, cleaning up, dishwasher, became a sous chef eventually, and eventually became a waiter. And that's when I started interacting with people. Believe it or not, I used to be very introverted. I like to keep myself and really had a hard time talking to people. But working in a restaurant definitely changed that in a very quick way. So not only did I witness how to work in sort of different environments, but also seeing injuries at work. And this is sort of my interest in occupational medicine at a young age, because I saw different workers getting injured. And if you're in a sushi bar and your sushi chef gets injured, what do? They're the essential worker, aren't they? You need a sushi chef to have a sushi bar. So what happens then? What do you do when coworkers get injured, whether it's a low back injury or other injuries sustained in the hospitality industry, which is numerous? What do you do when there's people coming in restricted duty, or if they're coming in or don't come in at all? And that's when I got introduced to the idea of absenteeism, right? That makes sense. People don't show up. You have nothing to do. You can't really do much. But what do you do when they do show up, but they can't work at full capacity? They're not fit for duty. They're there with restricted duty. So that's the idea of presenteeism. So this idea kind of stuck with me for a while when I kind of thought about, what do I want to do with my career? I wanted to do multiple things, and I thought, well, why not look at something where I can actually combine my love of medicine, of helping others, with understanding the rules of the game. So actually I pursued a 6-year dual MD JD program where I went to both medical school for 3 years and then law school for 2 years. And then in my final year, I did med school in the morning and law school at night. And luckily I was able to complete it all and be able to combine both of them in a career that I am today. I did start off as an eye surgeon initially, then saw the light and transitioned over to occupational medicine, which is a specialty within preventive medicine where I'm able to balance occupational medicine with employment and labor law, do a lot of environmental medicine with environmental law, and be able to actually integrate and balance the two of them together. And as a consultant now, I get to consult with companies from all different sizes. I actually teach a lot as well. I teach currently at Penn, my alma mater, at Dartmouth in community medicine, and also at University of New England. So it's been a great ride, and I hope to continue to do that and hopefully be able to do this more as I sort of integrate the work life. And the one thing I love about occupational medicine is that I get to balance out what I do, whether it's being a sushi chef one day, a lawyer another day, or being a doctor another day and seeing patients. But the great thing about occupational medicine is I can put different hats on depending on what day of the week, whether it's out riding a skidder in the North Woods, playing scientist when I was at NIOSH, going out and doing environmental exposure testing, working with industrial hygienists, or flying. I'm also a senior medical examiner for the FAA. So as part of that, taking care of pilots around the world, I get to fly, which is really amazing and a great time and a great opportunity for me as well. But my claim to fame actually is I'm actually the son of the queen of sushi. So I'm not sure if you have any sushi lovers out in the virtual world today, but if you've heard the Philadelphia roll, my mother is actually inventor of the Philadelphia roll. So that sort of makes me, I guess, the prince of sushi. Not really sure, but I'll take it. Some other experiences from the work environment. I did spend a lot of time at the VA and central office in DC looking at occupational medicine nationwide. Spent a lot of time at the Department of Labor at OSHA. Spent some time at the CDC under NIOSH, the National Institute for Occupational Safety and Health. Spent some time at the EPA looking at environmental health exposures and health effects, ATSTR, and public health, that's the US Surgeon General's office. So I kind of bring all of those experiences, tie it all into one, and try to bring it to sort of the hospital setting where I used to work in clinical for the past decade or so as a lawyer, understanding regulations, understanding parameters of what we function in, especially in healthcare, and most importantly in workers' compensation. But as a consultant, I'm kind of juggling it all now, whether I'm doing medical legal consulting or other work around. So the idea now is looking at what I need to do to understand and tie this into health and well-being. Because at the end of the day, if you want to look at health in a holistic way, you need to understand that. So I did a lot of work around some of my heroes is Sierra Coop, one of the first surgeon generals that looked at tobacco cessation programs, listing alcohol contents on alcoholic beverages. And because of that, we actually won honorable mention for a small community hospital here in Maine. I was sitting on stage with this Fortune 500 companies, and we're here as a small company saying, look, we're able to promote wellness and well-being no matter what size you are, and how do we translate that to the community? And I think that really ties into our topic today is, what do we need to do to be able to translate all this work that we've done at the national level globally so that we can help people who are settling claims? Does anything change because you're injured worker one day and the next day you're not, you're settled? How does that transition? How do we make that better? So I started thinking, what can I do to give back? So I serve right now as the current president of the New England College of Occupational and Environmental Medicine, where I had the privilege of working with the academic powerhouses of the US, whether it's at Harvard, where they sponsor a lot of educational programs, where I teach at Yale for some of the occupational medicine residents and fellows, at Dartmouth in community medicine, and also at UConn, partnering with them in some of their occupational and environmental medicine group as well. I'm also currently the vice president of our American College of Occupational and Environmental Medicine, future president, where I'm hoping to guide national policy, but also some global policy around what we need to do in occupational health and well-being. I'm also on the House of Delegate in the AMA, the American Medical Association, where we promote a lot of work around what physician organizations do, the future of healthcare, but also how do we advocate for those living in rural America, where I am now in Maine. And lastly, where Paul and I do serve as founding members of the Kids Chance of Maine, helping injured workers' children succeeding in education and promoting their scholarship and further education as well. So because of all that, I really had the opportunity to be an entrepreneur as well. And being able to do that, I would like to disrupt the well-being market. Right now, it's like the wild, wild west of well-being. And I had a pleasure of meeting Sir Richard Branson, who you see at the top of, about 6 years ago when he started to want to venture into the wellness market. And he actually started a company called Virgin Pulse, which he sold a couple years ago and merged with Redbrick, and had the opportunity of working with them and sort of designing the programs. How do we integrate technology? I mean, he's flying to outer space, right? I mean, SpaceX was really successful. And I think it's amazing to have someone that's his caliber to say, let's break into the well-being market and sort of well-being 1.0. And now I think we're at the future, which is 2.0. And that's where I like to talk as a futurist. I do a lot of talk to HR conferences. One of the keynotes I gave a couple years ago at Gillette Stadium, talking about the future of AI and machine learning and what do we need to do in the HR realm. And I'm happy to share with you today how I think that can translate from that into sort of what needs to be for folks in the post-settlement world as well. So let's try out some new technology here. We're going to have a poll, and I'll be happy if we can make this more interactive so that we can start going to questions and answers throughout, so we can see where people are at with this, and we can hopefully get this to work. So if you can, a poll just popped up right now. You can use to click yes or no. Have you ever met an occupational and environmental specialist before? And I'm going to hand it over to Paul as we transition over to the polling.
You know, Kenji, I have to tell you that I'm feeling like the underachiever in this bunch.
Not at all. I really enjoy what I do, so I feel like it's more like a hobby than anything else.
Yeah, I was going to ask you, Kenji, when do you take time to sleep? Because you certainly have a lot of very active, but I think that maybe that's your secret. If it's your passion.
I think this is why I got into the well-being, right? I don't want to be a hypocrite. If I want to say, look, you know, this is what I do, and I'm hoping that we can, you know, practice what we preach. And so, you know, sleep is very important. And people always ask me, you know, what's your takeaway from well-being? And there's just so much data and research out there, especially in the past couple of years, especially during the pandemic. But you know, I kind of break it down to top.
We have results from the
results. Oh, wonderful. So I'll come back to the top 3 because we'll go through that today. And before we end of this, I'll summarize that as well. And sleep is definitely part of that. So have you ever met an occupational and environmental medicine specialist before? It looks like 70% said no and 30% said yes. So, well, for those of you who don't know about occupational medicine and what we do, welcome. So it's a sub-branch of preventive medicine. So let's go to the next slide here.
Kenji, can I stop you there while you're going to the next slide?
Yes.
Do those numbers surprise you?
It does, especially for this group. I'm hoping before you settle, you've had some interaction with occupational medicine, because our specialty basically is those who care for injured workers. We spend 2 extra years in other physicians, whether you're primary care, urgent care, ER. We have 2 years of additional training specifically around injured workers. So I would hope that, you know, as part of your injured experience, your workers' comp experience, that you've interacted with someone in occupational health. Unfortunately, there is a shortage of us right now. So that could be a reason why, especially if you're in a rural community. I've noticed that we do have some shortages, as most of the statistics now say in the next 2 years, 80% of our workforce who are occupational medicine specialists are retiring as medical directors, and we don't have enough in the pipeline to fill that. So I'm hoping we can change that, and that's one of the reasons why my service now is to become the president of ACOM and other groups to promote sort of more people to get into this field, because most people don't know what it is. And we're hoping to change that from the sort of medical school realm, also working with advanced practice providers, training in that area, but also encouraging people to understand what we do and hopefully get more kids interested in this in medical school.
I think your comments are well taken, particularly in light of the fact that this is a self-selected group. These are folks who are interested in workers' compensation and have some either direct or peripheral responsibility in workers' compensation. To find that such a small percentage or have dealt with occupational docs. I happen to be somebody who thinks that they're critically important to the way workers' compensation works, while the injured worker is being treated pre-settlement, and then post-settlement, they're also very active, very important.
Yeah, so hopefully we'll change that today. I think it just takes one talk after another. We actually have a huge lobbying arm this year that we started at ACOM, working closely with the AMA to go to Congress. Right now, there's a huge CARES Act bill coming out that encourages public infrastructure funding, and we're hoping to allocate a little bit of that funding towards occupational health and occupational medicine training. So hopefully that's more to come this year. So thank you, Paul. I'm going to go ahead and move as I think Paul just disappeared off our screen. this is just to talk about the recognition of the different relationships we have and why I think it's important to have occupational health providers rather than your primary care doctor, your ER doctor, your urgent care doctors taking care of you when you're injured. Not only that, but even after settlement, even though you're no longer in the workers' comp system, it would be nice to have that transitional care. Why? Because I just recently wrote the OEM competencies, the occupational environmental medicine competencies, to what we need to have to achieve what we need for board certification and to be considered an occupational health doctor. And one component of that is well-being. So we just published that about last month. So you can go to ACOM's website and download that. I was one of the original authors and revisionists. So I kind of see that as a huge plus for us in the post-settlement world is how do we transition from saying, let's treat you as an injured worker, and then in post-settlement, how do we get you back to full functionality? It's all about function at the end of the day, because you want to be able to enjoy life, even post-settlement. You know, not all permanent disability is total impairment. So I think we need to understand that difference and be able to live life thereafter. So let's go into our next polling. Do you think injured workers identify themselves as injured workers after settlement? And this goes to a lot of the idea, you know, what do you think that means? Are you still the same sort of person? Do you identify yourself as an injured worker post-settlement? And this is a bit of a philosophical question, but I think it's also important to understand because it goes into discussion of what does that mean and how does that mean as a worker identity? So we'll give you a few seconds here while you answer that. And
Hey,
Paul, do you have any questions about this while we're waiting for the answers?
oh, hey, Kenji, I had a question for you.
Kenji, no.
Yes.
One thing I found interesting about what you're saying, that I know sometimes you're working with your patients to get them back to work, but other times you're just working with them to get them functional in the house and around, you know, around the house and in society. And you know, what do you see is the outlook and the goal about the same? You just want to get them up and active, or do you think about them in different ways when you're working with the patient?
Yeah, so that's a good question, right? And then one of the challenges and why we need specialty training in occupational medicine is that you wear multiple hats. Because, you know, as an occupational health sort of physician, I'm not always taking care of patients, and I always teach us in residencies. You know, you need to understand this conflicts of interest you have as an occupational health doctor, because some people traditionally called us the company doctor. And that to me, you know, is not right, because, you know, as a doctor, your Hippocratic oath is to your patients. But if you're not taking care of patients, and, you know, when occupational health kind of started as corporate medicine, back in when Ford started his company and hired one of the first doctors to work for a company, they were company doctors. And there was a huge challenge and conflict there, right? How can you be employed by a company, but also take care of their employees and call yourself a doctor taking care of patients? So it becomes a huge challenge and a conflict there, because you know, when you're dealing with workers' comp injury, however, they are your patients. And I always teach residents, when you go in and see a patient for workers' comp injury, make sure you understand, are they your patients, or are they coming for a pre-placement physical? Then they're not your patients, right? Or sometimes they're coming in as a claimant during an IME process, an independent medical evaluation. So we really need to understand how we're treating it, the patient. But I think in the post-settlement world, the beauty of that is all that collapses into one. They're your patient now, right? They're no longer in that claim system that you're used to in workers' compensation. The financial piece is taken out, because now you can really treat the person wholly and get them back to well and healthy, so that they are functional post-settlement world. And I think that's the key, is how do we translate and transition that care so you can get the best of both worlds. Companies are spending $4.5 trillion in well-being for their employees every year. So what does that mean? That's 5% of our GDP almost. That's got to mean something, right? Companies wouldn't invest that much into well-being unless there's something to it. So how do we take that sort of idea and work and translate to the post-settlement world, where now you're an individual again? You're no longer in the auspices of your employer, and you're a human being with different illnesses and injuries that needs to be sustained and helped. So I think that's really important. And going to the polling answers here, you know, it seems like 69% of us do identify as injured workers, even post-settlement, right? So we need to understand, so what does occupational health do in the specialty of treating injured workers, translating into the post-settlement world, where we know, let's focus more on function. Most likely you're not gonna be going back to the work you had before, but is there something you could do to enjoy the fruits of life? You know, how do you thrive?
Can I interject here for a second?
Yes, Paul.
Can I interject here for a second?
Please.
It always surprised me whether I was representing an injured worker or whether I was representing an employer defending a case, the frequency with which someone who was injured would see a physician, would have limitations placed on him, no lifting, bending, twisting, no lifting weights greater than 10 pounds or something like that. And the number of people who segregated that opinion to only apply to their work versus their everyday life.
Yes.
So what would happen is they would have a restriction placed on them. They would go out, not in the workplace, but someplace else, and be doing things beyond the restriction. They would get themselves observed by somebody doing that, and they would say, wait a second, I saw my doctor. I thought that only applied to my injury or to my work, and therefore I could lift greater than 10 pounds in my personal life. Do you see that in your practice as an occupational doc, that people sort of bifurcate their lives into work and non-work?
Unfortunately, yes. And this is why I always have to translate restrictions that I write for employers to the layman's person. What does that mean at home? So I always like to ask the question, what do you do for, for fun? What are your chores at home? So when I say you have a 5 or 10 pound restrictions, are you going to be able to carry 2 bags of grocery in one arm, walking into the house, putting it away in the refrigerator? Probably not, right? So you got to understand what that means into a normal person's daily life. If you're an avid exerciser, you're great. I'm always promoting physical activity, but if you have restrictions that you can't lift, push, pull, make sure you apply that when you're at the gym. I'm not saying that you shouldn't move around at all, because moving is good for you, but you got to make sure you follow those restrictions, whether you're at home or at work. And this is where that line blurs. Even though it's a workers' comp injury, I always teach my residents and trainees, you got to treat them as a person, because guess what? They have a life outside of work. Even though we spend a majority of our waking hours at work, 40 plus hours sometimes, it's encouraging and important for them to have a good home life as well. And how do you balance that so when they retire, they're able to enjoy retirement? And my patients love hearing that, because they want to think about life after work. Sometimes people love what they do and not feel like they're working, but some people feel like there is got to be an important distinction between home and life versus work life.
Yeah.
So I think that's really important. And this is why I kind of brought this idea up about sort of that social context of worker identity. And the question sort of ties in, right? 69% of us thought, yes, you're still considered an injured worker even though you're settled. In other cases, there's still a good 31% or so who said no, because maybe the idea of, I used to be a firefighter, now I'm no longer a firefighter. What does that mean to the individual? So they actually did studies about this for the past decade, looking at, so what happens to individuals who are injured? Their opportunity to engage in occupation and what they find is meaningful, and their sense of well-being does suffer, even just sustaining one injury that might be minor. Because if you think about it, folks who are working, who come back, sometimes don't want people to know, or their coworkers to know they have restrictions. There's a psychological shift in their mindset of an injured worker, and what that means, and just having that idea and the stigma behind it needs to be sort of diminished in some way so that well-being doesn't suffer. We kind of know now that there is a face to work and identity and what that means. How does that help in sort of the post-settlement world where no longer working? They might be doing another job, hopefully, but if they're not, how do we balance that? And a lot of data and research have come out looking at every year you work, you're actually decreasing your chance of dying by 10%. That's amazing, right? So this helps a lot in sort of the aging workforce and a lot of retirees who do not want to retire. Maybe they're volunteering or they're doing something because they know now decreasing your chance of dying by 10%, I'd take those odds to Vegas any day, right? I mean, that's great. But also, if you think about it, you're 3 times more likely to report being in good health and about half as likely having a serious health problem for every year you live, continue to work. So I think this is key, because a lot of the benefits of the stimulation, the social engagement is where we're looking at. And this still goes back to the idea of well-being, that 3 component, is social connectivity, sleep, but also making you have good nutrition. And I think this is why it's really tying in, and work offers that kind of social connectivity piece, stimulation that you can get. So how do we stimulate that? I think that's the challenge we have right now is, but work is not always good for you, especially if you're stressed at work. And this is one of the challenges I've had is, people do not enjoy their job. And I always encourage them, going back to the idea that you need to love your job. You need to be able to say, look, you enjoy so much that you feel like it's not work. And I think that's where you need to look at, because, suffering stress on the job has long been recognized as a risk factor for coronary artery disease and stroke. So you develop heart problems. Your job is physically demanding. You might have increased risk of injury if you're out lifting, 50-pound bags of salt and moving it around, or if you're doing heavy lifting out in the woods. It can be pretty challenging and physically demanding on your body as well. So you need to feel that your job sort of means something, so you don't feel bored, because otherwise you start burning out as well. I think that's why it's really important sort of to look at that. So overall, I think it's really important to look at what factors affect wellness. And then the idea of that is, I kind of break down into the triad here as well. It's really your mind. How do you develop a happy mind? Your body, your physical activity, and also your spirit. You have a meaningful heart. You're really engaged in what you do every day when you wake up. And these sort of the top 3 things I look at as a sort of a well-being, whether you're in pre-settlement, post-settlement. And it's sometimes challenging in workers' comp because sometimes it's adjudicated in a very different way that can be adversarial sometimes, but sometimes it doesn't need to be. And I think that's where we need to look at this. And for those employers on the line right now, it's huge. I mentioned earlier, 4.5 trillion being spent on this yearly on employees. If you look at sort of the happy mind model, mental health right now, especially this past year, has exploded. We're spending over $121 billion on this in this market. In regards to physical activity, we're spending $82 billion. In regards to sort of meaningful heart, and especially how it's estimated, we're spending about $48 billion. So this really adds up over time. And the question now is, if big companies doing this, how do we translate this to post-settlement worlds that people have settled, continue to sort of bear the labor and the fruits of all this well-being initiatives we have in the workforce to the non-workforce thereafter?
Hey,
Can I stop you there? Unless Porter has a question, of course.
Yeah. I was going to pass the mic to you, actually, Paul. So maybe I can bounce it off you, and you can throw in your question.
Okay.
I was curious, when you've represented injured workers, how much of the mind, the happy mind, comes into the idea around settling, because it's just such a relief to some folks to settle the case. And I was curious to get your perspective on that. I think that does factor in sometimes.
I think that's huge.
I can tell you, Porter, that for some people, settling brought them peace of mind. Settling, they may not have got along with their employer. They may have hated the job that they had when they were injured. They may not have got along well with the adjuster who had the file. And as a result, the whole workers' compensation process was pretty stressful for them. So it was a fairly easy transition for them, I think, to get out of workers' compensation and settle their case. But I can tell you that I had plenty of discussions with people I represented, injured workers, about what are you going to do now? What's your life going to do? And they, many of them talked about developing hobbies. I had one guy set up a little business where he's making signs, commercial signs. I had others that tried to do, take some of the settlement proceeds and maybe set up a small engine repair shop or something like that to keep themselves busy. But I think Kenji's put his finger on something that I think, and as a company too, we should think about the people on our platform, keeping their minds alive, keeping them interested in things, and not just wallowing on the fact that they're injured. I think the injured workers who seem to do the best, who were the ones that accepted the fact that they had an injury, accepted the fact that they were going to live with some limitations, but prepared to get on with their lives doing other things. Kenji, would you agree with that?
I wholeheartedly agree. And this really ties into my next topic about the social determinants of health. Part of that is your mental health and well-being. How do you translate that from being sort of that worker identity, right? You're an injured worker. How do you make that shift so that hopefully, eventually you don't see yourself as an injured worker anymore? Because guess what? You started your new business. Growing up in a small family business, an entrepreneur, I want people to start businesses. We're in a capitalist society, and we thrive in that, and we need to flourish now health-wise. And how do we do that? We need to tie in sort of the overall idea of what does health and well-being mean, so you can shift that mindset, saying, you know what, I didn't like the job I had before, but guess what? I'm still good at making signs. I can still do things with my fingers. And for those of us who are amputees, I have a really good video at the end. And we have technology now to support you and to be able to accommodate you into what your heart desires. As long as you understand that the data shows, right, the longer you work, the meaningful engagement you have in life, the longer you live, you'll have less chronic diseases, so you can actually enjoy your life, but also take that idea of saying, let's settle so you can move on. And I think that's sometimes hard, especially if you identify yourself as a worker. Police officers and law enforcement is a good example, firefighters, doctors. We kind of identify our job as who we are, but sometimes we need to move beyond that. And I think this is where the idea of the social determinants of health kicks in, because guess what? Relationships matter. That ties into your health. Your housing matters. Nutrition, safety. Guess what? Oral health. We know about all of this. So I think it's really important to understand how that really ties in. But guess what? Especially in this day and age, now we're looking at sort of the DEI world, right? Diversity, equity, and inclusion. I think we need to really talk about that as well. how does that tie in? You know, when we look at race and socioeconomic differences, especially in workers' compensation, what do? One of the #1 injuries we see, and I think post-settlement as well, is occupational low back injury or any kind of spinal injury. We have back injuries. So this is an interesting study that came out that said, guess what? Let's ask the question of why we're seeing these disparities. Health disparities existed way before DEI became a big issue. And I think the results here show, you know, the study looked at sort of post-settlement pain intensity, psychological distress, disability amongst African Americans and non-Hispanic Caucasians and the workers' comp claimants. And this showed that, guess what? Risk factors for poor outcomes after low back injuries do exist when you take into account race. So that's just the beginning. I'll come back to this again when we talk more about pain and how we sort of achieve the idea of alleviation.
Just so everybody in our audience knows, Kenji, the SES is social and economic status, correct?
Yes, SES is socioeconomic status. So that's how much income you generate over a year. And we look at the poverty level as to consider whether you have low or high socioeconomic status. And I'll come back to that again too, because that is such a huge piece of what social determinants of health look at, you know, because now we know race is one component, one factor, economic, and we've known this for a lot longer, that socioeconomic status definitely has a huge factor here too. But when we look at outcomes, you know, here's a good example. If you go through a knee surgery, and the question is, how often do you need to get resurgery? If you look at the one bar right there going up and down, let me move my head so you can see me. Right here, when you look at 1, that's where your risk is normal, 1. So if anything higher than that, your risk has increased. So what does that mean? So if you're a female, you're almost about 1 to 1.25 times more likely to have reoperation in your knee. If you're in a workers' comp system, you're almost 1.75 times likely to have reoperation in your surgery. If you're white, you have a higher chance, and if you're older. So it's quite interesting. I'll come back to this again too, because guess what? What if you factor in race? So this just came out. So I put it into a quick spreadsheet to calculate. You know, if we look at discrepancies between African Americans, looking at almost 33%, and Caucasian about 52%, they're not being diagnosed appropriately for disc herniation, right? This is for back injuries again. If you look at, there's a huge, even a larger difference if you look at surgery rates for these diagnoses. Whereas, you know, if you're African American, you have surgery 22% of the time, but Caucasians get access to emergent surgery a little sooner at 48%. So if you look at socioeconomic status, SES again here, same thing. People with higher socioeconomic status has surgery. People who are poor do not. So the question is why? And this survey actually asked the question why to the African American group and said, okay, what are you worried about? Why aren't you, if you know this is disc herniation that requires surgery, you've been recommended, why aren't you doing it? They're worried that they don't have money for it, because if you use money for surgery, you're not going to have money for food. That's 85% of them. 82% was worried about where they're going to live, because they're usually paying for apartment for rent. Any money that's not in their pocket that week, they live paycheck to paycheck. 62% can't afford to see a doctor. Even under the workers' comp system, they know it's going to be covered. If it's an accepted claim, they still have this worry. Why? Because it's trickling from the health effect, right? And this is where the social determinants of health is so important, especially when you look at race disparities and look at socioeconomic statuses. It's such a huge factor that we need to take this into account. If we want someone to be well and healthy, you can't be blind to the idea of the social determinants, their existence as a force for health. And this ties into and affects a lot of things like sleep, fatigue, pain, the way you idealize and sense pain, and well-being. And this actually was measured, showing that how it decreases the longer the injury persists. So despite 91% of the people going back to work, functional limitation persists into workers' comp injuries, even if it's a minor workplace injury, because of the psychological component. So I think that's really interesting. So I think I've talked a lot about psychology, so I want to go into the idea of, what does it mean for the brain? So when we take a little break here and go to another question, and maybe we can turn it back to Paul and Porter as well. So does feeling excluded change the structure of your brain? So while people are answering that, we can talk about what that means.
So what you were just telling us, Kenji, what would you tell us that we should be doing with people on our platform who bring some of these concerns to our attention? What's the advice that we should be sharing with them?
Yeah, a lot of it comes down to knowledge and also trust. It's unfortunate because if you look at the makeup of healthcare providers, sometimes that doesn't mirror exactly the patient population they're serving. Especially when you go out to rural community, which is most of America, It's hard and challenging sometimes to seek someone who speaks the same language, understand the same culture, and understand implicit bias. So we've done a lot of training this past couple of years around implicit bias, which is the idea that you understand and see that people do have biases that never surface to what they perceive as conscious. So it is unconscious in a lot of ways. So as we increase education around that perspective, it's nice to be able to do the same for the patient perspective. From the post-settlement world, how do we break down that stigma? How do we identify people so they're no longer seeing themselves as injured workers and move on to the next phase of their life? How do they balance out their socioeconomic statuses? How do they balance out the access to care? Where are they living? Are they getting good access to good food? So I think that's really important. And this goes back to the idea of your brain, and because sometimes it's a biological issue, it's a chemical issue, not a character issue. So I think this is a good question here. People do understand that. I guess most people are sort of insinuating my leading question here, but yes, your brain does change in a very interesting way. Because I think that really ties into the idea of how do we address the social determinants of health? It's through social connection. We now know, if you look at various brain studies, we can actually image now live where we see parts of the brain and parts of the blood flowing and when you're interacting, when you're on opioid or if you're on treatment. The idea of being excluded, we have social connections that you can see here. Your brain is pretty much active when you're interacting with people, whether you're interacting in a positive sense or a negative sense. You can see it here that your brain is quite active. So actually, if you don't mind taking the polling off, I think I lost my slide there.
No, thanks. Yeah, I was going to say it.
Right there.
Let me share an observation with you.
Yes.
One of the things that struck me when I started working for Ametros that I never seriously thought about when I represented injured workers, or even when I functioned as a regulator, is that the day before settlement, the injured worker the claimant has usually an attorney. Nationally, that's true. They have a claims adjuster for the insurance company. Whether they like that person or not, they're still available to answer questions and give them good advice. They may have a nurse case manager who's available, and they may have a company physician who is available, and any number of other people. After the settlement, particularly if they're not going to be working with a professional administrator, they step away from the workers' compensation system, and all those folks are gone. So when you think about what you're telling us about feeling excluded, suddenly this person's world, a significant part of their world, is gone, and they're by themselves to take care of their financial and most importantly, from our perspective, their medical needs and the payment of their medical needs. So it seems to me that one of the arguments that you could make is that settling and being on your own is probably not a good idea.
Definitely not. You need that support network. And this is actually showing the proof here, right? If you don't believe, sometimes seeing is believing. Your brain's telling you, you need to do this together. And this is one of the challenges of the post-settlement world is you don't have no longer that niche, the people you show up to work with every day, that collective that you're used to be part of. And that's so important because if you look at animal studies, right? We've heard this terminology before, fish school, birds flock. What does humans do? Right? A decade ago, there's a book that came out called Tribal Leadership by Dave Logan and John King. A lot of people are teaching this in MBA classes now because why? Humans tribe, right? We collate as groups of people, and that's important. And even through the settlement process, I think it's so important to have that connection to the world, to understand what's going on for everybody else, and finding that purpose and that engagement in life again so that you can stay mentally and socially well, because I think that's so important to understand that piece as well.
Hey, Kenji, and I think you shared with us before that you've had some patients of yours that you treated up until they had a settlement. And what from the doctor's side, what have you seen happen with their continuity of care or their treatment patterns?
Yeah, I think it's so important that sometimes when they settle, it's like a brick wall for a lot of folks saying, okay, we're done. And some clinics, unfortunately, only deals with workers' compensation. So that's like, okay, you're no longer in a workers' comp case, you're done, you need to go see your primary care doctor now. And that's a challenge, right? Because if you develop this relationship, and I think that relationship is sacred, that doctor-patient relationship, it's so hard to recreate that when you have a trusting bilateral relationship where it's therapeutic. It's so important to hold on to that for as long as you can. because you don't want to have all of a sudden to stop that and not be able to continue. I think having that sort of gatekeeper, that person you can trust to understand to refer you to the right specialist, making sure you stay on track with your goals of getting to be functional again, and people who specialize in this, translating this to the post-settlement work is so important and crucial, and having that social connectivity. As occupational health specialists, we're trained to understand and see this and catch this, and if you need to, refer you to the right specialist to get that help and to get that connection and get that treatment, whether it's alternatives to opioids, whether it's treatment new modalities, using technology to advance some of your functional status. How do you find accommodations in your new work life, your new hobbies, your new home life? So I think it's really important to have that. So along those lines too, the question then becomes is, maybe there's the next polling question, so we can get this up. So does rejection hurt as much as physical pain? I think this is a stigma. This is where I'm emphasizing is the question becomes, how often do we see this as an issue? Because if you see rejection and physical pain is different, sometimes it's hard to understand. So I think it's really interesting to see what people say about this and to understand whether there's something we need to do to address the stigma and to be able to address the biases and be able to encourage people to understand and think about this in a new way, because it's very different. So let's close the poll and see what people have said. So yeah, so 88% thinks that rejection is hurt just as much as physical pain. And guess what? I can show you now. If you look at the brain, we actually have physical and social pain overlap in the same areas of the brain as you're sensing physical pain. So now people can't just say it's in your head when you're in pain. And I tell my patients this all the time. They're like, nobody believes me, I'm in pain. I'm like, I understand, because pain is something you perceive. We understand that there are different parts of the brain that receptors now, the science is there to show that physical pain is emotional pain, social pain are regulated in the same parts of the brain. This is what's amazing about the fMRI technology, because now we can use and show that blood flow to parts of the brain is there, the circuitry is there, the pathway is there. So have you ever personally treated yourself via telemedicine? If so, how do you compare that with in-person treatment? So let's do this as an open-ended question. So feel free to put in your chat box, because I want you to wake up again and get engaged and start typing answers into the chat box as I kind of discuss this. And I think Paul or Porter had some questions about this too. Do you want to bring that question up now and I can talk about it?
I think what we're seeing because of COVID, Kenji, I think the literature is showing that there's been a dramatic increase in the number of telemedicine visits, in large part because physicians didn't have their offices open. One insurance executive was telling me that she saw in their company a 2,000% increase in the use of telemedicine. I'd be very curious from your perspective as a physician, is telemedicine as good as, something less than? It's a nice alternative, but not quite as good as an in-person visit. And are there some areas of medicine where it's better than others?
Yeah, I think this is huge. I mean, luckily, I've been in health informatics for the past decade. I've always had an interest in technology as a self-proclaimed sort of futurist. It's so important. And I think one of the lasting sort of medical legacy once the pandemic is behind us is the idea of digital health. It helps increase access to care. The question is it equivalent care? And that's where it's harder, right? Because we don't have the technology that caught up quite quickly yet. But guess what? I've been pushing for telemedicine for a decade now. It's existent for almost 20 years. We've had it since computers and the VA actually is one of the first to integrate their systems together and have telemedicine for some of the CBOCs that they have, the clinical-based outpatient clinics in rural communities. But we never really came to fruition. But luckily with the pandemic, I think one of the silver linings, I should say luckily, one of the silver linings of the pandemic was it pushed a decade of telemedicine within 1 year. And you can see it now. And I think technology needs to catch up. It's existent. I work with a lot of startup companies right now with peripheral devices. I used to say, look, I need to be able to hear your heart. I need to listen to your lungs. I need to see your eyes. Guess what? We have technology now, just with your phone. This little thing, is the same computer we used to fly to the moon, right? It's all on our phone. And we have peripheral devices now that can actually allow me to listen to your heart, listen to your lungs. If you put it up to your eye, I can see the back of your eye for diabetic retinopathies. Put it into your ear, put a pulse ox on your finger. Guess what? I have all your vitals. There's so much data out there now that I think we can start doing this in very different ways. The Internet of Things, there's so much data out there. Machine learning, it's going to be huge. I can't be up 24/7 as much as I want to be. We asked about sleep earlier. There's only one of me, but if I can somehow output a lot of my brains to an algorithm, have an artificial intelligence chat box on my website to answer questions, guess what? That just made life easier for a lot of people who have similar questions I've answered before. Is there a way to gamify things? Is there a way to engage people in different ways? I'm working with multiple startups right now, understanding behavior. How do we change behavior? And to me, it's changing of habits. How do we change habits? With your phone, right? With your watch. We have all these wearable devices now. There's so many things we can do to really engage changing your habit, eventually become changing your behavior. So I think this is going to be huge and one of the lasting impacts of telemedicine, the importance of it, and that technology evolves to keep up with the idea of medicine. I think we're going to get there. And I'll talk about virtual reality and augmented reality because that's going to be huge for us.
Kenji, let me share with you some of the observations made by some of the people attending this webinar in our chat box. One comment is that yes, but this should never replace face-to-face. And another one is disconnected feeling with telemedicine as opposed to meeting with a physician in person. How would you address those two observations, both of which seem to ring true?
Absolutely. And this is a good question because the AMA brought this up as well, the American Medical Association. And I think the importance of it needs to be both. The idea is access to care is the paramount, right? If you live 80, 90 miles away from your doctor and you need to come in for a follow-up visit, why can't that follow-up visit be in telemedicine? You know, and then see your doctor every month or every 2 months. If you need to see them every week, it's sometimes challenging. And if you have peripheral devices where you can actually see your doctor, talk to your doctor can get your vitals using peripheral devices and technology. I think there's a balance that we need to balance because there is a human component that I would say is so important to medicine. And this is why I always tell people, no matter how smart we get with artificial intelligence, that will never replace being a doctor. Why? Because that human connection. There's a whole study of pheromones and the exchanges of chemicals that we have when we talk to someone face-to-face versus virtually. You know, today we tested a lot of new technologies, trying to interact with you as much as I can from the audience in the world. But, you know, it's not the same as being— I think
that technology just got you, Kenji.
What was that?
We lost you for a few seconds there. Another person in our chat makes the observation that telehealth really depends on the doctor and how well the doctor handles telehealth. Are you hearing comments from patients at all about how technically proficient some physicians are as opposed to others in the use of telemedicine?
It's quite interesting, actually. We did a survey looking at age groups of people who are early adopter to telemedicine. So Paul and Porter, what do you think? Do you think it's the younger generation or more seasoned generations who is adopting telemedicine at a faster rate than we expected?
That's a good question. I almost wonder if it's in the office, the capability of the office staff to facilitate all this. I think a lot of us think of the doctor as this kind of ivory tower person that does everything. But one thing, I don't know the answer, honestly, but I would think if you have a really good staff around you, they figured out telemedicine, the billing, and the setup. That might be one of the determinants. I don't know, Paul, what's your thought?
I think that's true, Porter. I think that one of the nice things that I hear physicians saying about telemedicine is that it eliminates the waiting room and the patient waiting for the doctor to show up or see the next patient. I can tell you I've had more than one discussion with physicians who've treated me that I had an appointment at a particular time. I've been sitting in the waiting room for 45 minutes. My time is valuable. I'm thinking about billing you for that time. And sort of, I say that facetiously. I have a reasonably good relationship with the physicians that I see, but by the same token, I think that's one of the nice things about telemedicine is you can cut through all of that. The doctor can call you at 5 after 10 or whenever when they're available. You can just sit at home. You can be reading a book. You can be living your life. You can do whatever, and then the call comes up and you can deal with the physician. So I think that's one of the advantages as well.
Absolutely, and that's exactly true, especially if you're looking for a specialist that doesn't exist in your neighborhood. Traditionally you have to fly somewhere or drive 4 or 5 hours. If you're in northern Maine, going down to Boston might be a 6-hour drive. So in those cases, I think telemedicine allows you access to specialists. As a specialist myself, I'm on a telephone for people in Omaha, Wyoming, Montana, like people who don't have occupational medicine specialists. So I think that perspective is nice. So now they're able to communicate with me I'm able to see them, not do everything necessary quite yet, because like I said, technology is not quite there yet, but I think it's going to get there. But interesting, the survey result actually showed it's the seasoned generation, not the younger generation, that's adopting telemedicine quicker. And the reason is a lot of younger trainees weren't trained to use telemedicine. So they're very uncomfortable not being able to touch the patient, make their physical exam and diagnosis the way they were trained traditionally. So initially, the uptake of telemedicine was challenging for those who are more newer to medicine. You would think, oh, they're younger, they like technology, so they're gonna probably be able to adopt it quickly. And that wasn't the case in most hospitals. But now we're starting to equilibrate. People are starting to understand there is a way of doing this where, guess what, if they need urgent care, they're gonna come to the ER, they're gonna come to the urgent care. We figure out what it is, and if we can triage it through telemedicine initially, I think that's an okay step. So we're going to get there. It's going to take a couple more years, I think, before technology catches up to what we can do, what we should do, especially around the virtual reality, augmented reality world. I think the options and limits for medicine is almost insurmountable. It's going to get there.
Hey, Kenji, you and I did a program with a psychiatrist back 9 months, 10 months ago. And one of his comments was that he thought telemedicine was going to play a major role in his, at least for talk therapy, after the initial visit. He thought the initial visit was critical to do it in person, but then he said all follow-up visits for talk therapy purposes might do best if they are via telemedicine. So.
Yeah, no, I agree. And I think that initial visit, that's what I meant, like the hybrid approach, right? See them at least once. For any urgent care, anything that needs to be done more interval, that's a good option for telemedicine. I completely agree, especially around psychology or psychiatry, mental health. That relationship's so important. So once you have that relationship, you understand the jive, that vibe you get between the two people interacting with each other, then I think everything else can be done through telemedicine.
Yeah. Hey, Paul and Kenji, there was a question a few minutes ago from the audience, which maybe Paul, you might jump onto it, but Kenji too, interested in your thoughts, which is, we hear a lot about connectivity to others. I think when we were talking about social determinants being important, however, where does the responsibility of the employer end? And maybe that factors into settlement too. How does the employer stop being involved, and how do you work through that? I don't know, Paul, if you want to talk about the transition from pre to post settlement, or Kenji, any thoughts there too?
I think employers can make that transition painless, and I think they can make it seamless as well. There are times when I think it just makes infinite good sense to settle a case. There's a predictability to how long the person is going to be incapacitated. There's a predictability to what the future medical is going to look like. And I think rather than simply carry that person on the books, so to speak, and monitor them on a regular basis, it would make sense to cut them loose, settle the case for a reasonable sum, and do it in a smooth transition. And I've seen that done repeatedly by certain employers. And I think, to talk about Kenji's or response to some of Kenji's earlier comments, I almost think it's therapeutic in some situations to get people out from under and to allow them to get on with their lives. Kenji?
No, I completely agree, and it helps with the healing process as well, because sometimes your body needs that rest, that homeostasis that you're looking for. And the external stresses of your employer saying, you know what, I want this to end. The employee wants it to end. Sometimes the adjudicator doesn't want it to end. That's not a good situation, and it's hard because if you're self-insured versus when you're fully insured, there's different financial drivers going on there as well. But from the patient perspective, and as a physician treating these patients, I think it's kind of hard to understand and push for that, because I've seen cases where now I often observe as a physician advocate in Maine, and I see these cases that I'm like, why hasn't this settled? It doesn't make sense, and it's being dragged on, and they're never going to get better unless they can move on to the next phase of their life. And I think that is so important, because if you're looking for the functionality and sort of the bouncing forward, the idea of resiliency, you can't do that until you can have sort of finality. It's almost like a bad breakup, unfortunately, in some of these cases. Sometimes it just needs to happen, and it just takes too long. And the longer you wait, the more function can sort of be impacted. And it's a lot of the psychological and physical component as well. So yeah, I agree, Paul.
Yeah, I think one thing to throw out there for clarity too of post-settlement administration and Ametros's role, it's really after settlement on for the rest of their lifetime. So the employer or the carrier has settled the case, it's fully and finally they're released from liability, and our agreements with the injured person. So we kind of get that breath of fresh air that I think Kenji and Paul are talking about, which is we're here to service them and their settlement funds. And a lot of what Kenji has brought to our attention too is to have that continuity where if they were seeing certain doctors that they really valued their opinion, we try to make sure the injured person can get plugged in with them and kind of keep their care path forward. But the employer, the insurance company at that point is totally out of the picture. They've settled the case.
The other thing that happens too, Porter, is that stepping away problem that I identified earlier. We step into that vacuum, and we have staff available to call and respond to inquiries that the people on our platform have. And if you talk to our staff who do that, they get calls about all kinds of things, in large part to harken back to what Kenji was saying earlier. Sometimes people just want to talk. They want to have a community, and we step into that community need.
There's another question from the audience. Maybe I'll send to you, Kenji, which is, sometimes, and this doesn't happen with us after settlement, but I think it is a big issue before settlement. Sometimes there's an impact on the injured employee if there's utilization review or medical treatment denied. What are some things that are potential workarounds? And the common is, sometimes injured employees can fall into a depression or, fall into areas where they have uncontrolled pain or lack of treatment because of that utilization review decision. You and Paul, I'm sure, have come across this in your past experience and could comment to some ideas around it.
Yeah. Do you want to start, Paul, or do you want me to start? So I think utilization review has its importance. They look at evidence-based medicine. Unfortunately, that's another hour talk about what that means. But they have different guidelines they're using to say, what does utilization review mean? So as for me, when you present evidence, there's always two sides of it, right? This is putting my attorney hat on, saying, look, I'm here as an advocate for my client, or in this case, I'm an advocate for my patient. I usually have to call the utilization review panelists and say, hey, how did you come to this decision? I'm using my decision based on these evidence. These are the cases, these are the randomized controlled trials that we've seen. This is an effective modality for treatment. Guess what? Your denial of this is going to cause more psychological harm, and it's going to affect the longevity of this case, of this healing process. What do we do to address that? So you need that advocate, and this is where I think having an occupational health provider who specializes in this can tell you as a patient what are the pros and cons of approaching different modalities. But to me, I always have a backup. In medicine, we teach you think and differential diagnosis. If this works, then it's not, then let's move on to this. If not, then move on to this. So you always have a plan A, B, and C. So that way I always tell my patient, don't despair. If this doesn't work, if this gets denied, there's alternatives, there's options. We're not stuck. This is not the last straw. This is medicine. We're advancing every day. There's technologies out there. There's other modalities we can use. So we need to serve as that capacity, as that that ray of hope. Because without hope and without sort of the idea that you're going to be getting better, they're not going to get better. And this is why I treat my patient as an individual, holistically, saying, guess what? We have plan A, B, and C in place. So don't worry about what the utilization review panel comes back with, because I have options. We have options, and we can do this together.
Yeah, I think part of utilization review and fee schedules came into the workers' compensation system in large part to control costs and to control what was going on. And as often as not, utilization review is a good thing to prevent abuses, but by the same token, some people don't fit. One size does not fit all at all times. And I think there has to be some flexibility. If there's 12 visits that the utilization review says that the patient should have, there should be a little bit of flexibility that maybe 14 will work or maybe 16 will work, and you got to be willing to do that.
Well, on a big question, Kenji, what excites you about the way medicine is going, and what do you think is some of the most exciting things to come in the space?
Yeah, I think we're such in a digital age, a golden age of what we can do, what's going to happen, and I think the future is almost great in that we have options of technology, and I think the technology is going to be key, and what we can do with this. So let me just share my slides once more as we kind of close out the talk for today. And I think we need to understand that we've advanced technology to a point where we can help people with different needs. Understanding the different pain receptors and using technology to help really advance what we can do. How do we harmonize the idea of holistic well-being initiatives to the blended work-home life? whether it's pre-settlement, post-settlement life. How do we balance that? And I think it takes time, but guess what? In 2021, we've learned a lot. There's a lot we can do with facial recognition technology. There's robots out there that's going to be help assisting us in different ways. There's mini robots checking temperatures for fever. We have different interactions that we have now with robots and human touch. How do we get that social connectivity? How do we interface a brain with different ideas of what amputees can get? You know, we have all this technology now that's really useful. And I just want to share one video as we kind of end up is what can we do? This just came out last week from Google. This is the idea of an injured worker who was electrocuted, unfortunately, lost his limb, and had to figure out what to do because he was a drummer. So I'm going to play this video.
And there's a lot of nuance with exactly how the drumstick reacts. Things as subtle as how tightly do you grip it, how does it bounce. They're really hard to calibrate if you don't have a machine learning system to gather all the data.
When I heard about Jason's story, it really blew my mind. I was like, whoa, I had no idea how far we have come in terms of AI and prosthetics.
So the way the arm operates is we use EMG, which stands for electromyography. Basically what that is it's sensors that are amplified by a battery that pick up electrical signals from our residual limb.
Using these signals, we are able to do recognition of complex patterns with machine learning and then map them to specific movements. TensorFlow Lite is doing that in real time.
And so I can flex my muscle and it will tighten the grip on the stick, and I can extend my muscle and it will loosen the grip on the stick, just like it would with a normal hand.
No, the latency is like none.
Awesome, that's awesome. And in the last few months, we were able to detect almost 100% of the time this intention.
I can actually feel the feedback from the arm, and it feels as close to a real hand as you can get without it actually being a real hand.
That's amazing, right? We're able to actually have someone use their hand where they couldn't use it before. So I think being able to use that technology, and I think the future of medicine is here, whether it's peripheral devices, telemedicine, other options. I think we have a lot of potential now to show that we have the capability, the willingness, and now the question is how we're going to get there. So I'm really excited to see what where the future takes us and what we have and how we can translate everything we've learned for the injured worker and translate that to post-settlement world as well.
Awesome. Well, Kenji, thanks so much for your perspectives, research, and your time. And Paul, always a pleasure. We really enjoyed this webinar and the value you bring to us and our partners. So
We're going to go out for some sushi now.
All right, you all. Well, thanks again. Have a great day.
Thanks, everyone.
Good seeing you. Good seeing you.